Jacob, can you smell that? You smell that?
I smell it. As soon as you came on, I smelled something. I just wasn't. It's like, what is it? It's just it smells.
That's burnt almonds. Yeah, I just got this. This great new beard butter. It's like,
oh my goodness,
it smells like almonds.
Oh my goodness, that's what is that? Like, what I smelled?
Like roasted burnt almonds.
You know what's weird though is that you mentioned it, and I'm actually getting a little bit lightheaded right now. I feel like my mitochondria, like the oxidative chain or whatever, is like not working.
That is the same smell as cyanide.
I figured it out. There we go. All right, perfect.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
So now that we got that out of the way, the other thing that I did want to say is that, you and I talked about this a few days ago, that things have been a little shaky with the Ultrasound podcast the last few months. We haven't been as consistent as normal. Right. I think that has something to do with the fact that, I moved, you moved.
I moved.
Dawson bought a castle.
He's now literally a king.
Kinda. He thinks he's a king.
Right.
So we want to, how do we want to do this? Do we want to take a pledge? Do we want to take
I'll pledge right now.
We pledge to be better about, I think it's right hand. Don't kneel. Quit kneeling.
Everything's so politically charged these days.
I know, man. You can't do anything right.
I know.
I really want to get better about releasing the podcast a little bit more regularly. So I think we should shoot for once a month. How's that sound?
Done. Yeah, no, we can totally do it. Yeah. Once a month. You heard it here. January, whatever.
It's the new thing.
Once a month. It's the new thing.
Yeah.
New digs. Sure. Sweet. So what are we doing? What are we doing this time?
We're going to have some awesome people on the podcast today.
So excited.
Talk to us about peritonsillar abscess, but we're going to do it from a different approach. Recently had this email string go through with ULA. We've got this email string of all the current and past fellows, and it's 100 people or something. But somebody asked the question, can you drain a PTA in somebody, or without an endocavitary probe, or in somebody who can't open their mouth completely? And we got this huge string on all these different ideas, and one of them was this idea of doing it from a submandibular approach, which is pretty cool. I've never done it, and I've always been kind of a hater on that idea because I feel really good about going in the mouth with endocavitary.
The one time that I did it, my issue was that I went through the carotid.
Yeah, so you don't want to do that.
And so I didn't do it after that time that I went through the carotid.
Through the foramen magnum, which is I thought I was just going to hit it from the back.
So that's why we need to have Andrew and Brooke come and tell us, because we don't really understand how this works, and we need some experts.
Yeah, Jacob, so tell us, who are we having on the podcast?
So we're having the one and only Andrew Liteplo and the one and only Brooke Hensley come and talk to us about this crazy approach about doing, what is it that they called it, Mike?
The submandibular telescopic peritonsillar abscess. I don't know, something like that. Yeah. It's pretty, it's a sweet name, whatever it is. Yeah, it's got a lot of syllables and stuff. But the reason we chose these guys is because they put together a super cool video, which is on the MGH website, which we'll link to in the show notes. And we're going to play that video as well for you. So we're going to talk to these guys first. We're going to talk a little bit about, why submandibular versus endocavitary versus inside the mouth approach. And then we're going to watch their video, and then we're going to call it a day.
Sweet. Sounds good.
Awesome.
Let's see it.
Do it.
All right. I'm ready to go.
Yeah, I'm ready to go too. Guys, thanks, Andrew and Brooke, for coming on to the podcast.
Thanks for having us.
We've asked you to come on because recently I was privy to an email that went around the ULA listserv. We've got a listserv of all of our current and past fellows, and somebody was asking about doing peritonsillar abscess drainage without an endocavitary probe. And I got to admit, I've always been kind of a hater on the how do you call it? The superficial technique, what's the description we should use here? Is it transcutaneous?
No, you said telescopic. No, he said telescopic. What was the word you used?
Submandibular approach.
Yeah.
See, that sounds. So if somebody had called it the telescopic submandibular approach when I first heard about it, maybe I'd be more into it. But whatever. So I'd always thought that I'd always thought the endocavitary probe, the endocavitary probe technique was the best, and probably because I started off in med school doing that. So I think my like 4th year of medical school, I drained a PTA with the endocavitary probe, and I was immediately like, "Whoa, this thing is awesome!" Like, this is how I want to do it. I'd always learned to kind of do it with the needle in the mouth with the probe at the same time, and I never really paid much attention to this technique of doing it from under the jaw. And I think that's because I had a probe and I was comfortable with the way I was already doing it, right? So, complacency, right? And now I've moved. I'm out of an academic setting. I'm actually in a spot now where I don't have an endocavitary probe. So I've got no option unless I'm going to try to fit like a linear probe in somebody's mouth, which I could only do with Jacob's mouth. And I don't think like now I'm like forced into learning this technique. And then somebody mentioned on the listserv about this super cool video that you guys did, which I recently watched, and we're going to play on the podcast in just a few minutes. So I wanted to have you guys on and talk about this a little bit, talk about the technique a little bit more, because I feel like it hasn't really I know it's got no airtime on Ultrasound podcast, and we haven't talked about it too much in the world of ultrasound in general. So I've got a probe here, and let's just say that I've got some trismus and I can't open my mouth. I need you to tell me, like, where do I put the probe on my face to see the abscess? Is it here?
Yeah, and also Mike is playing the role of a chipmunk that also happens to have a peritonsillar abscess.
Where do I put the probe? I don't know where I put it.
Well, you'd have to shave the beard maybe, so maybe this is not.
All right, here, I'll put it on Jacob. Where should I put it on Jacob?
All right, here. No, I'll use my phone. All right, where does it go?
So the submandibular approach, put it literally underneath
like this?
I like to do it with the probe marker toward the line a little further in, kind of where you might feel a carotid pulse, and just kind of imagine where the abscess might be and just point straight up there.
So are you using a linear or a curved probe? Because it looked like a curved on the video that you guys.
Well, Jacob doesn't have his curvilinear phone, so right now, linear. But either one will work. I kind of like the curvilinear because it gives you a little bit more of just a broad field of view. Okay. If you have a linear one with the extended field of view, it would probably work pretty well.
Like how extended? How extended are we talking? Like how many centimeters do you need to get up there?
Oh, I don't know, Brooke. What is it, like 5, 6?
I would say at least 5. Okay. I've never tried it with a linear probe, but I feel that the curvilinear has worked great for me the times that I've done it.
Yeah.
Okay. And then you guys have done like ultrasound guided technique too. So you're actually draining it under guidance of the ultrasound.
Which is crazy.
Yeah.
That blows the needle is not anywhere near. I mean, you're not going from the outside, right? You're not doing like a percutaneous puncture, right?
Oh, right. You're putting the needle through the mouth, and you can actually see from afar, which is the whole idea of the telescope. Because I'm, as someone who likes etymology, right? So in Greek and Latin roots, right? You're looking from afar, and the needle is in a different place. The only other time I've used this is for like a pericardiocentesis, where you're doing a parasternal long view, and you're draining from the apex. But the same kind of concept. Your needle is remote from where the probe is.
So how do you manipulate the probe then so you get the needle in a long axis? Like, are you twisting the probe some so that it's more like, it's not really like lined up with the submandibular space? Like, what's the adjustment that you do to get it in so you see the entire needle?
Yeah, so I think it is a little bit more challenging because it's not like an ultrasound guided IV placement where you're right up against the skin, right up against the probe. But you line it up where you think the angle is that you're aiming toward the peritonsillar abscess itself, and then you'll catch a glimpse of the needle. You'll see a hyperechoic bright spot, and then you'll kind of look where your hand is, where the probe is, and the angle of the needle, and then you sort of try to line them both up.
Right.
I mean, I've never been able to do it right away. I think it takes a little bit of finesse, but if you just see one part of the needle, then I think you can adjust either your hand or the probe or both to get it lined up.
So you're kind of adjusting the needle. You're kind of adjusting the needle in real time, or the probe in real time, once you catch the needle in view, sort of.
Mm-hmm.
Yeah. So what I like to do is have them poke with the cap on, So you can kind of get a little preview of what you might see. So the abscess you should see no matter how your probe is rotated. But if you rotate it so it basically is in the direction of where the needle is coming from, and then they're poking, before actually having the needle exposed, you should be able to see the plane that it'll be coming in.
Yeah, that needle cap technique you were talking about, Andrew, on the video is super cool. Like you could totally tell where the needle was. Right. Where the needle was pushing on that abscess, like whether there was directly over it or not. Because that was the other question I have is like, where do you stick the needle? Do you just kind of go where it looks like the abscess is? But then that's basically blind. But I like you keep the cap on and then you poke on it. I'm sure the patient loves that. They're like, you know, you put it on the back of the throat with a cap.
It's better than having an endocavitary probe and the light and the needle all at once.
You can't hold all those things. I put the light in my mouth one time because I couldn't have anybody to help me. So if you and it's actually works really well. Like you take the otoscope and you turn it sideways like this, and you just bite it with your teeth, and then you've got two hands to work with for the probe and the needle. That's the Malin maneuver.
Speaking of not having enough hands, do you guys, is this like a 2-person technique, or can you be poking the abscess and hold the transducer?
Ooh, I don't think I've tried it alone, but you probably could do it if you're really good. I like to just supervise the residents anyway, so I do the ultrasound part and let them do the drainage, and it's worked out very nicely.
I think you probably could, Jacob. I mean, you know, you hold the probe just like you would the endocavitary probe with your left hand, and then the needle with your right hand, assuming you're right-handed, and then just manipulate the probe. You could probably even get the patient to hold the probe once you got it in the right position, right?
Yeah, that's actually a good point.
It depends on how cooperative the patient is. And, you know, sometimes they're holding the light for you and they're awesome, but sometimes you just need to have someone else helping you. But it is possible.
Yeah. Or you can hold the probe and have the patient do the needle.
I'll try. I'll definitely try that.
Little to the right.
Yeah.
Well, go ahead, Jacob.
No, I was going to say, I have one question that is kind of burning in my mind, and that's this. Is this what you do on all of your patients, or do you do this when you can't get the mouth open enough to do the endocavitary probe? Because for me, that's been my issue with the endocavitary. Mike's in a place where he doesn't have an endocavitary probe. I've tried this real-time guidance with the endocavitary probe, and my problem is I cannot get. The way that I do it is I'll do a laryngoscope. I'll get like a 3 or 4 blade, and I'll have the patient hold their tongue out away with a light. I usually can't do that, get the transcavitary or endocavitary probe in there and the needle and see what I'm doing at the same time. There's just not enough room in the mouth because they're so trismatic. Trismatic?
Is that a word? Trismatic.
Trismatic.
Got
that I can't do it. But if I can open their mouth, should I be doing this endocavitary-ly, or should I do this always the way that you're doing it?
Studies never been done. This is my go-to, and I haven't had trouble with it since we started doing it. We also didn't have an endocavitary probe for a long time, so it kind of became our go-to from that. Mm-hmm. But you know, it's been really successful, and people like it, and patients like it, and so it's my.
In your experience, easier than endocavitary approach?
Yeah,
I think so. And I think people always tend to gravitate to what they know, because a lot of trepidation for using ultrasound to begin with.
Sure.
If they're not used to using even an endocavitary probe, they're always just going to do a needle aspiration and kind of guess a few times.
Yep.
And then, you know, taking an extra step, doing the submandibular approach is also, you know, it's a little bit scary if you don't know what you're looking at. But I would encourage anybody, even if it seems like it would be a very easy peritonsillar abscess drainage, just to try to see what you see with the curvilinear probe and try to do it with this approach, so you kind of get used to the anatomy and get used to the feel of it.
So tough questions. If you can't tell with the curved or the linear probe from the telescopic submandibular approach, which just rolls off the tongue, by the way, if you couldn't tell from that, would you then try the endocavitary approach, or would you do a CT?
Couldn't tell what?
Couldn't tell whether there's an abscess. Like say there's like sort of this homogeneous sort of area, and you're thinking, maybe it's cellulitis, maybe it's really hypoechoic pus or hyperechoic pus, you know, like, but you're just not ready to commit.
So I definitely think there's a role for endocavitary probe with that, because what you don't get is the ability to compress with the right. Because if you're pushing the submandibular, you're just pushing the entire abscess into air, and you won't be able to tell if there's mobile material within that abscess.
Hard to see the swirl.
Unless it's anechoic or hypoechoic, you might not be able to tell. So there would be a role for an endocarotid probe from a diagnostic standpoint. Now, once you do that, you see it is an abscess, then you probably could go back to the telescopic approach for the drainage portion.
Nice. Nice.
And don't forget comparing to the contralateral side, just to see if you know, you see a lot more swelling, maybe it's not as anechoic, but you see a lot more soft tissue swelling. Just always compare and see if you can convince yourself otherwise that there is a fluid collection there.
It's been like probably 4 years since we've talked about peritonsillar abscess on the podcast. It's been a long time. And I feel like this is one of those areas that lots of people have tips and tricks that I'm just not aware of. So I'm curious to hear your guys' tips and tricks regarding what do you do about needle length and how you prevent from stabbing the carotid and getting shot in the face with blood.
Seems like a big deal. Seems important.
Sometimes, yeah. What do you guys do about needle length?
So the thing that's nice is you can see on the ultrasound where the carotid is, and you can measure and see how far it is, how much space you have to go. But I always like to cut the needle cap off.
You're a capper.
So I know it cannot, so it can't go any more than 2 centimeters or whatever length I choose. I actually had a patient once in residency. She was actually very cooperative. She was letting me do my thing, but as soon as I went in there with the needle, she had a syncopal event and fell forward.
Oh my gosh.
I was really glad that I had that cap on there.
You're like holding her up with the needle.
It's like the vertebral bodies. You're holding it up like the C-spine.
I think it's a good point, because with the ultrasound, you can measure the exact distance to fluid, right? Cap it. And if you're hubbed, the answer is not push harder or further, right? You're in the wrong space.
Right. You're in the brainstem.
Yeah.
Just a bad place to aspirate. Right on. What do you guys like for numbing? Do you do aerosolized lidocaine? Do you do benzocaine? Banana spray?
I like aerosolized. I put it in the nebulizer and just have them sit there with that for
Good idea.
like 10 minutes, and then I'll also do topical injection.
Nice.
Right.
Cool. Any more questions, Jacob?
No, that's it. Thanks you guys so much for coming on the podcast and talking to us about this. And we'll let you know if any other cool video service that we'd like to talk to you guys about.
Yeah, awesome. Thanks for having us. It was really fun.
Thanks for having us.
Yeah, super cool.
Sure.
Thanks for y'all's hard work with that video that you put up on the MGH website, which, do you want to plug it? Plugs?
Yeah, plug it.
Plugs?
Sure. Check out our website, MGH. Oh, I don't even know. MGH US.
We'll put it in the show notes. Don't worry.
I don't know.
It's like, wait. No, hold on. I've got it right here. Let me pull it up. It is sites.google.com/site/mghedus/home.
We're gonna put a link. We're gonna put a link. It'll be better.
It'll be
It
a
was
link.
off the top, like telescopic submandibular approach.
Awesome. Thanks, guys. I really appreciate you coming on.
Thank
the
you.
All right, guys. Take it easy.
Hey, this is Brooke Hensley. I'm the ultrasound fellow at Massachusetts General Hospital, and today I have Andrew Liteplo, our emergency ultrasound fellowship director, has a cool case to share with us today.
Hello, Brooke. Hello, everybody. So this is an awesome case we had last week. It's a 20-year-old male, no medical problems, a sore throat for the past week or so. He had seen his doctor, diagnosed him with strep, and started him on antibiotics. Didn't get better, so a few days later he went to another hospital, and they diagnosed him with, they said, you have a peritonsillar abscess. And he said, they stuck a needle in my mouth 3 times. They called the ENT doctor. Nobody could get fluid out. So they sent me home. So now he presents, and his swelling's getting worse. He's having difficulty speaking. And this is what it looks like. So what do you think?
Well, definitely based on this patient's exam, my top differentials would include a peritonsillar abscess or a peritonsillar cellulitis.
Good. He's clearly got this unilateral swelling with some uvular deviation, and it's very prominent there, right? So what would you do?
So, you would think that by your exam you'd be able to differentiate between peritonsillar cellulitis and an abscess, but I've definitely been surprised in the past. So what I normally would do is use an ultrasound to see if there's a fluid collection there, or...
Good. That's the
if it's
perfect
just
answer
cellulitis.
as an ultrasound fellow. But I will tell you that my resident had already ordered a CAT scan for this patient until I saw him, thankfully, before the CAT scan had happened. And so we went to do an ultrasound. So how do you do an ultrasound for peritonsillar abscess?
So normally what I do in the past is I grab an endocavitary probe, not a transvaginal probe. You never want to say that around a person.
Right, never say I'm about to stick the transvaginal probe in your mouth.
Yeah. Make sure you cover up the probe appropriately, and then you place the probe inside the patient's mouth, or actually sometimes I've had them place it in their own mouth, and place the end of the probe right up against where the swelling is.
Good. And what you can sometimes see is something like this. So this is a nice round area here. It's quite anechoic or very hypoechoic in the middle. And you can see that the footprint of the probe is actually touching that area. So you can see comfortably that this is an abscess. You can also see the carotid, and it's quite deep to the abscess, but that helps visualize that. Good. So that is a technique that is commonly used. I personally have had some problems with that. One of them, what do you think?
So the thing that's nice about the endocavitary probe is that it can fit inside the patient's mouth. It's the only probe that fits inside the patient's mouth in order to see the abscess or swelling and see what it is. However, once you identify it using the endocavitary probe, you have to remove it and then follow it up with a blind poke.
Right. And so the two big challenges are mostly that you see these patients with trismus that can barely open their mouths. You're putting this gigantic probe in their mouth, and you're using up most of that real estate of the mouth. So to get a light in there and to stick a needle in there makes it very challenging. The other aspect is that when this is done correctly, you've got the probe touching the exact spot where you want the needle to go. And so actually seeing your needle and following it in real time becomes a little bit of a challenge.
So even when I've seen a very clear fluid collection, sometimes I still end up poking the patient 3 or 4 times, trying to find the exact spot where I had my probe before.
Right. And the other problem is we didn't have this endocavitary probe. So what we did is we actually used a curvilinear probe. And I've done this before also with a linear probe. Here we see a very gray-haired gentleman we see the probe. This is the location. And so we've got the probe marker right here pointing posteriorly, and the front's kind of toward the front of the mouth. So if you think about what this looks like on your screen, we see this image right here. Okay, so just some anatomy here. Here's the tonsillar area. The carotid is right here. And here's air and tongue with inside of the mouth. And what do you think of this image?
Well, it definitely looks like there's an area of hypoechoic and heterogeneous debris in here that would make me concerned for a peritonsillar abscess.
Absolutely. Now, it's not always this clear. Sometimes it doesn't look as anechoic, and you have to kind of squish it or compress it a little bit or have a very high suspicion. But in this case, we saw a very nice round abscess that we knew definitively right there he did have a peritonsillar abscess. We canceled the CAT scan right away, saved some radiation, able to measure it. And so you can see the measurement's about 3 by 3.5 by 3 centimeters. And we knew right there what the size is and that he definitely had a peritonsillar abscess. So this is the submandibular approach.
Great. So once you make the diagnosis, so you would still have to do a blind stick, right?
Well, you would think. But actually, no. We have ultrasound, and why not use it for guidance?
Well, normally when I do an ultrasound-guided procedure, I always put my needle where the probe is, but clearly you're not going to be sticking the needle externally and draining it externally, so how are you going to do this?
Good point. Okay, so, we're not going to stick the needle through the skin to reach it because your carotid is right around here, and that would be too risky. So we're going to do what I call a telescopic submandibular approach, right? It's telescopic because from the Greek, that means tele, at a distance, scopes to see. So we're seeing and we're guiding from a distance. So the probe, and this is the only procedure I can think of where the probe and needle are not in the exact same place. The probe is still on the outside underneath the chin, and the needle is going to go in the mouth. So what I had the resident do, and he had never drained one of these before, I first had him take this needle, and you can see right here a needle with the cap on it, and I said, poke around in the mouth, and I'll keep looking. Look where you think that fluid might be. And when he got to this point right here, I said, that's it. And I could see he was only about 1 centimeter or less away from that fluid with no concerning structures in the middle. So we knew that that was the location. He pushed kind of hard, made a little indentation of the needle cap there. And then we prepped his needle. So what are the advantages of doing this? Why don't you describe this?
No matter what approach you choose to use, it's always great to think about your safeguard preps. And here you can see how close the carotid can be to the area where you want to poke. So here we're doing a needle aspiration, and we measured that the peritonsillar abscess fluid is about 1 to 2 centimeters from the surface of the abscess. So we cut the cap and put it back on the needle so that if the patient seizes or syncopizes, which has happened to me when draining an abscess, and I was thankful that I had this cap on, that it's actually a safeguard for you.
Yeah, perfect, good. So we did exactly that. We put a cap on for about 2 centimeters. And then I had him anesthetize, right? So here, put the needle in, and he went a little deeper than I thought. I was hoping he would just get the anesthetic right in the actual tissue, but he went a little deeper, and watch it again. You can see as he's injecting the lidocaine, the fluid cavity is filling up with that lidocaine. So we knew he's in the right spot. He then withdrew the needle, and I said, put the big needle exactly where you anesthetize it, where the patient has that little drop of blood. And you can see, here's the needle, and he's entering the cavity. You can see the needle tip right here, enters the peritonsillar abscess cavity. I can see it the whole time. The patient's comfortable. He's got a fully open mouth with which he can shine a light in and see exactly where he's going. And once he's in there, then we just had him aspirate. And you can see that he aspirated the fluid, and that black area inside the cavity is shrinking to the point where there's nothing left, and the cavity is completely obliterated.
This is great because you can actually see the needle in real time like you would normally do with any kind of ultrasound guided procedure involving a needle or any other sharp objects, and you can also keep your carotid artery in sight and know exactly where you are at all times.
Right, exactly. And it requires a little bit of rotating your probe so that you see the needle in plane in the long axis, but it's very easy to do from a superficial point of view. The patient was quite comfortable, and we were all able to watch the needle the whole time. And so once he aspirated and removed the needle, we actually got about, well, that was exactly it. It was about 10 cc's of this purulent material. Got a little blood at the end. It kept squirting out of the mouth, hitting us in the face. It was very pulsatile.
And the patient syncopized.
The patient syncopized. We couldn't figure it out what happened, but we just assumed that he did fine. No, I'm kidding. The patient, we didn't even come near the carotid because you can see we capped the needle safely. The patient was amazed at how great he felt and how quick it was. He said something like, "That's it," and indeed, that was it.
All right. So some take-home points. Number 1. Don't ever say transvaginal ultrasound probe, but you don't even have to say it if you're going to use the telescopic submandibular approach. And when you're using this approach, you can use the linear or the curvilinear probe. It's also really important to cap your needle when you're doing this procedure.
Right. And the patient did well. We saved his CT. You couldn't imagine how excited the resident was. He had stayed 2 hours after his shift just to do this procedure because he was so busy. And he said, wow, that was worth every second. He left with this giant grin on his face, as did the patient. So great. All right. Well, thanks everybody for listening, and
visit our website.
Visit our website. Thanks.